back to another episode of Coffee with Coker. My name's Mark Rybolt. I'm the host, and on this episode, we're doing another presentation recap. So we recently did this on presentations that were given at the recent AHLA Transactions Conference in early May. And this is another presentation, or recap of a presentation that was given at that conference. And today we're joined by Aimee Greeter, who's a senior vice president here at Coker. And her co-speaker was Toni Peck, who is an attorney at Nelson Mullins, Riley and Scarborough. And Toni and Aimee have worked together alongside mutual clients for a number of years and have presented at conferences. And at this conference, Aimee and Toni presented, the title of the presentation was Maximizing Physician Engagement to Drive Clinical Integration Success. So there's a lot there. There was a lot to unpack in the presentation itself. We just spent, honestly, a few minutes going through very high level covering what they talked about. Toni talked a lot about the legal and regulatory hurdles and variables that you're going to have to deal with, whether you're from the hospital or health system side, or if you're from the physician practice side, whether you're a CIN or some other type of similar organization. There's a lot to deal with there. Most of you are probably familiar with that, maybe have gone through that. But she did a really good job in the presentation and the slides themselves to unpack a number of those different hurdles and different variables that have to be addressed. And there are a lot there. Aimee talked about what she calls physician engagement assessment tool. And that's something Coker puts out there, which we will make sure in the show notes that we have links to or copies available of the material itself, but also the assessment tool. That's something that we've talked about on the podcast before. Aimee has presented a lot on it and written white papers on it. And so there's a good bit out there on it, and it's been extremely helpful, proven to be very successful with our clients. And so that's something we want to make available. And Aimee walks through some of the key components of that assessment tool and some of the key takeaways from the actual presentation itself. And since it was a very, one of those topics that there was a lot of interest, we did want to recap it and make that information available. So as always, if you have questions or want to hear more about this or learn more, make sure you can reach out to Aimee or Toni directly. They'd love to talk to you. And you can also find this episode and all of our previous episodes at coffeewithcoker.com. So you can find us there. And last but not least, I just want to mention this, since this was a previous presentation given, we just wanted to put a disclaimer out there that nothing in here constitutes as legal advice. And Toni isn't providing legal counsel in any way, and this is all just discussion around the topic. And again, I thought it was a very good one, and so we look forward to getting your feedback and to hearing if this is something of interest to you, or if you would like to hear us cover another topic in the future. Please give us that feedback. You can reach out to us directly at feedback@cokergroup.com, or you can contact us through the website at cokergroup.com directly. And as again, our episodes are available at coffeewithcoker.com, and you can find us also on social media at Coker Group. So with all of that said, we hope you enjoy this topic, and we'll look forward to hearing from you on future episodes. All right. Well, welcome. We have Aimee and Toni Peck, who is from Nelson Mullins, an attorney, and Aimee Greeter, of course, who is the senior vice president here at Coker. And as we mentioned in the intro, we are doing another recap of a presentation that Toni and Aimee just recently gave in early May of 2019, talking about maximizing physician engagement to drive clinical integration success. So there's a lot there. I know there was a lot to unpack in the presentation itself. But first of all, welcome, Aimee and Toni.
Thanks so much, Mark.
I'm really glad we could talk and dig into this a little bit here, at least even for just a few more minutes, because I know it was a popular topic. It's always a popular topic. And I know it was, well received, and there was a lot of interest from the AHLA Transactions Conference on this. So I guess maybe I'll just start off by saying what were some of the key things you guys talked about, and Aimee, maybe kick us off if just some of the key takeaways from the presentation itself.
Sure, absolutely. So Toni and I were fortunate to give this presentation twice at the AHLA Healthcare Transactions Conference in Nashville recently. And I think the fact that we had the opportunity to present it twice gives us a little bit of insight into what a pressing topic it is. So we really started the presentation talking about engagement as a requisite to support a successful transformation to the new healthcare paradigms that we're facing in the industry. So we're talking about things like using clinical integration to take advantage of evolving payment models, to looking at how we can use engagement to maximize success under value-based payment reimbursement, and also looking at how do we use engagement to create organizational transformation. So how do we use engagement to really foster a culture that is supportive of the way that healthcare is moving. So Toni and I both definitely played our parts to our strengths. Toni talked a lot about using clinical integration and how to do that in a way that is legally compliant and certainly meets all the appropriate regulatory parameters. And we used a case study of a clinically integrated network, a CIN, as one method for responding to the new paradigms within healthcare. So Toni can speak a little bit to that, and then I can speak a little bit to practical methods for engagement. What's the how? How do you actually get providers engaged, both in clinical integration structures as well as within their broader organization? So Toni, do you want to fill us in on some of the legal parameters?
Sure. Thanks, Aimee. I think as Aimee said, we know that value-based payment is here. Risk-based payments are here. And I think alignment it's just not enough. We've got to be more clinically integrated to be successful in these value-based payment environments. And one thing we also know is that physician engagement is the absolute crux of any successful clinical integration, which of course includes clinically integrated networks. There's a variety of definitions for a clinically integrated network, but it basically is just a collection of providers using defined metrics to have a result of lower payments, higher quality, reduced costs of healthcare. And there are a number of legal and business considerations when considering how to develop a clinically integrated network. Some examples include, what is your business corporate structure going to look like? Are you going to be a limited liability company, a nonprofit corporation, a subsidiary of one of the participants? The other things that we can look at is how to craft your governance in a way to achieve the success of your network. Who will the participants of your network be? You have to ensure that you've got the right amount of specialty mix to drive the coordination of care. You want to add providers that will improve access to reasonable payment rates, providers who are willing to embrace a value-based reimbursement model. We want to ensure that providers are invested in the model of your clinically integrated network, and they're not just joining because their friends are joining. And, one of the other things we need to think about is how you will use information technology. How will you use your EHR? How will you use your clinically performance management systems to ensure that not only is the right clinical information being put into your information technology, but you're getting out the data and information that you need to drive clinical success within your network. And of course, the important question of how will the clinically integrated network be funded? I think this is a conversation that needs to be honest and open and transparent. The participants need to know what the finances look like and not just sort of the projected financial plan, the best of the best, so that people will join your network. They need to know their financial risk. If it's a health system that's joining, ensure that the clinically integrated network is also aligned with the health system's plans for itself. Is the clinically integrated network going to support your quality targets? Is it going to help you expand a service line, give you access to a geographic area that you don't have? We've got to ensure that when health systems join clinically integrated network, it's not because everybody else is doing it again. And it truly is because it is part of a strategic decision. And of course, anything having to do with healthcare, there are a plethora of healthcare regulations and rules that we need to follow or at least abide by. Here, it's the antitrust laws. The best way to do that in a clinically integrated network is to, of course, get the opinion of an antitrust expert, but a lot of that is based on the FTC and DOJ guidance. Stark and anti-kickback and civil monetary penalties are also an issue. One thing to mention, however, is if your clinically integrated network is an ACO, you've got a lot more flexibility with Stark, anti-kickback, even antitrust, than you would if you were not, because the FTC, DOJ, EMS, and the others have given special exceptions for ACOs. But we also need to think, in addition to these federal laws, think about state laws. Some that are important are state insurance regulations. I know in North Carolina, where we are right now, there are certain defined terms that must be put in provider agreements with managed care entities for a clinically integrated network. You also have to ensure that your clinically integrated network abides by the corporate practice of medicine. You don't want, depending on the structure that you have, you don't want that business entity providing clinical services. So non-medical entities or persons do not control any clinical aspect of the clinically integrated network. All practice of medicine issues should be done and controlled by licensed practitioners. So basically, the clinically integrated network is just it's a tool amongst others, is to ensure that you've got the best way to handle value-based care. And one of the crux of a clinically integrated network, as I said before, is physician engagement. And the structure of a clinically integrated network is basically based on the success of how engaged your physicians are. For instance, physicians, while this network should be led by business persons, in terms of management, it should be led in terms of clinical management by physicians. And Aimee, I think you're going to take us through just how we can actually achieve physician engagement.
Thanks, Toni. She did a great job during the presentation, and I'm sure that was just a snippet of sort of her expertise. So the audience was definitely treated to some great insights by Toni. As Toni mentioned, the other half of our presentation really talked about engagement. So we started by talking about the differences in engagement, sort of at the 50,000 foot level, and then we walked down and looked at deciphering engagement at the individual level. So at the 50,000 foot level, we talked about differences in engagement by demographics, recognizing that some of our seasoned providers, the 55 and older, our baby boomers, have different forms of engagement that work for them than some of our Gen X and millennial providers. So we have a lot of older physicians, seasoned physicians, I guess is the right way to say it, that have said, I'm towards the twilight years of my career, and so engagement to me really means you give me enough runway to be left alone and kind of do things my own way. Whereas some of our new physicians have a very opposite stance on things. They want communication different ways. They want it much more frequently. They want to have more decision-making power. They want to feel part of the fold. In addition to demographic differences, there are definitely differences in engagement by specialty. So one of the things I think is interesting is that primary care physicians, while they tend to have the greatest level of alignment, meaning that so many of our primary care physicians are employed right now, they actually test out to have the lowest levels of engagement. I think a lot of that is because they're often partnered with health systems, but not present in the system. Most primary care physicians don't round anymore. There's hospitals that do that. And so even though they're aligned, they really have low engagement. The converse is true. Orthopedic surgeons tend to test off the charts for engagement, even though they have relatively low alignment. So things like bundled payments in which health systems and orthopedic surgeons have to work together really drive a lot of that engagement. So there's a lot of joint discussions about the ways that the surgeons work with their health system partner that drive that. Likewise, there's differences in geography. So urban providers tend to be less engaged than rural providers, mostly because there's some competing forces in the market. So urban providers don't necessarily have to be as loyal, and that lessened loyalty can be less engagement as well. And then finally, we talked about cultural differences in engagement. So there is an instrument called the OCAI, the Organizational Culture Assessment Instrument. That is a great tool for looking at culture within an organization. And so I recommend anyone that's listening to that, if you're interested in defining culture within an organization, you can look at the OCAI. And then what we did is we really talked about how do you assess engagement at the individual provider level? And so we went through the assessment tool that has 12 dimensions of physician engagement, which are tested, and it's 26 questions total. We've made that resource publicly available to anyone that's listening to that podcast, and Mark's given instructions on how to do that. But it's a great tool to be able to use and also customize to make sure that it hits what is most important. And then the results of that assessment tool can tell you on both an individual level where physicians are scoring, whether they are highly engaged or whether they are at the lowest forms of engagement. And then you can do some trend analysis to show what are the aggregated results of your assessment tool telling you about your organization, and where are there really areas for opportunity to improve your provider engagement. The last thing that we talked about during the presentation was just improving physician engagement. So once you get those results back from your engagement assessment, what do you do about it? So we talked about 5 practical tips and then sort of one bonus one to talk about what do you do to get physicians engaged or really either turn your organization around or to drive some of the operating successes that most organizations so badly need. We talked first about developing a shared mission and vision. We talked about nurturing physician leaders. We talked about the importance of communication. We talked about capturing and sharing accurate data. And then we talked about involving providers in the development of metrics and how do you hold physicians accountable. And then finally, as a bonus, we talked about working toward clinical integration. I think one of the more interesting points that came out of the discussion was just questions from the audience about holding physicians accountable. So to that 5th practical point, how do you hold physicians accountable, particularly when they aren't engaged and they don't want to be engaged? How do you really bring them into the fold and then hold them accountable for their behaviors, whether it's sort of low engagement or high engagement? And so we talked about, as an example, a clinically integrated network that we've worked with that has 4 stages of accountability. So they have data that's shared with physicians, again, talking about capturing and sharing accurate data. And then they look at the performance data to see where outliers are. And so within that network, if there are physicians that are consistently outside of the normative behaviors, they have a 4-step accountability plan. They have an informal meeting first in which a physician peer meets with a physician. They have formal written documentation as a second step. They third have a remediation plan that's developed and outlines the necessary behaviors. And then fourth, they move for expulsion from the CIN for providers that are consistently outside of the normative behaviors and aren't making any headway in reformation and changing their behaviors. And so it's things like that that we talk about, really holding physicians accountable, having their peers do that, and having some very explicit standards for behavior as possibilities for success within CINs. I think the whole bottom line, at least for me, and I'll let Toni speak to it too, is that physician engagement isn't just a rainbow or a unicorn. You know, it's not something that's fluffy and nebulous and a nice to have. It's something that's a business imperative at this point, and it's becoming more so over time. And so one of the biggest takeaways for me was recognize engagement as a business imperative. Number two, engage your providers in myriad ways so that you get all of your providers engaged in a way that works for them. And then number three, keep behaviors in line by using physician peers and physician leaders to continue to role model, to continue to assert, and to continue to drive accountability for those behaviors. Because again, it's not a nice to have anymore. It's definitely a must have. Toni, do you want to make any comments about or key takeaways for you?
Yeah, I think one of my key takeaways was how important the data you're going to collect within, whatever sort of data it is that you do collect, how important it is to use that data. It is important for physician buy-in. It is important for sustaining it, and it certainly is important if there is failure to be able to fix what's going wrong. There's no way that you're going to survive in a value-based payment arena without the use of the data. So I think that's just one thing that was important.
And I think that's interesting, and I think it even brings it full circle, because I know you guys specifically talking about engagement in a value-based reimbursement world, and I think that it's already coming. It's here to a certain extent, and it's something that's for sure in the future as they're thinking. And I thought this was interesting just because, talking about, Toni, you talk about the legal and regulatory hurdles that an organization is going to have to consider and eventually work through when they're going through both alignment scenarios and just the ongoing physician engagement efforts. And then, Aimee talking about measuring and optimizing engagement. But it's so often, I know we work with clients all the time where they may do a really good job focusing on one of those things. And maybe they work a lot on the mechanics, but then kind of, drop the ball a little bit on the ongoing engagement piece. And I think that's where the assessment tool comes in. Or they're really good at the physician relations and engagement piece, but there are a lot of holes there, whether it's antitrust or it's fair market value, compensation, whatever it may be as far as compliance goes. But I think it has to be this full model, and going through this process, not just going through it once and then putting on the shelf, but literally continuously going through it is a necessity as far as making sure these efforts are successful going forward. So I thought that was extremely helpful. I really appreciate you guys doing a quick recap of this, and I know it's something that gets a lot of attention, a lot of interest from our followers, and so hopefully we'll be able to talk more about this with you all in the future. So thank you, ladies.
Thank you.
Thanks so much.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them, and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us in a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback, and we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.